Okay. Yeah. There we go. All right. Good afternoon, Chair and members of the committee. Thank you for the opportunity to be here. My name is Sarah Muller. I'm the Vice President for External Affairs with the California Association of Public Hospitals and Health Systems. What I'd really love to do is just build on Ms. Cantwell's comments and talk a little bit about what the waiver means from a public health care perspective and how we see some of this incredible work really going forward over the next 5 years. First, just to give you a sense of who the public hospital systems are in California, we represent the 17 designated public hospital systems in the state that are all the county-owned and operated systems and the 5 UC medical centers. Together, they play 3 really critically important roles in our communities. First, they are major safety net providers in both Medi-Cal and in the uninsured, and often serve as the core safety net providers in their local area. Second, they are providers of critical community services. That is often the place where many patients go for specialty care, as well as burn and trauma services, services that you wouldn't find in any other facility. And third, they are largely the educators of our next generation of physicians. Together, they train just under 60% of the next generation of doctors. And so even if you don't get your care at a public health care system, chances are you're physician trained at one. As the public healthcare systems really started to think about the upcoming waiver negotiations and where we could be supportive in the state's effort, we wanted to really do 2 things. One is we wanted to think a lot about where we thought our systems needed to go over the next 5 years, what they should look like at the end of the 2015 waiver. And together they developed a mission statement that was very focused on being integrated systems of care with high quality, accessible services, and really taking a greater ownership for the health care and the overall health of the populations that they serve and the communities that they operate in. And so you'll see some of these themes weaved into some of the programs that we were fortunate to be able to work with the state on and to be able to have success with CMS and being able to implement. In addition to that, we also really wanted to build, as Ms. Cantwell said, on the success of the prior waiver. We were participants in the low-income health program and were core to the DSRIP program and wanted to build on our lessons learned and some of the great work that had happened over the last 5 years. As Ms. Cantwell talked about, the low-income health program was the launching pad for a very successful Medi-Cal expansion, and the DSRIP served as our pay-for-performance program to get our delivery systems ready for ACA implementation, so that when someone had access to a Medi-Cal card, they then could get access to an appointment, and our delivery systems were more prepared to be able to take those patients in and to provide good care. That really kind of then leads us to these programs that are outlined in the 2015 waiver. And I'll first start with Prime, because that builds so much on what we did with DSRIP. But as Ms. Cantwell highlighted, Prime is the next, I don't even want to say next chapter, since it is so much more, it's kind of the next leap with pay for performance in delivery system improvement work. The programs outlined in Prime are much more standardized, very heavily focused on clinical outcomes and overall health improvement, and they require year-over-year improvement. So if our systems knock it out of the park in year 2, they don't get a free pass for year 3. They have to build on year 2's accomplishment and demonstrate continued improvement every year of the waiver. It's exciting, but I will say it is challenging. So what does this look like from a patient perspective? And let me offer 2 stories to help kind of illustrate what this looks like locally. Lori is a patient in Los Angeles who's been going to one of our clinics for a number of years. And through the DSRIP, she was enrolled into a medical home and assigned a primary care team. So they had much better access to help coordinate her care, make sure she was getting appointments on time, and developed a real rapport with her. Under Prime, our federal funding will now be contingent on our ability to improve Lori's health. We have to make sure we're managing her diabetes more effectively. We have to make sure she's receiving her scheduled mammograms. We have to screen her for depression if we think that that might be something she's struggling with. We have to help her stop smoking if she's a smoker. And we have to capture her race, ethnicity, sexual orientation, and gender identity information so that we are beginning to identify the health disparities, not just for Lori, but other patients that may be struggling in our systems. Stanley came to us through the trauma center at Alameda Health System. And as part of his recovery and through the DSRIP program, Alameda Health System worked really hard to coordinate both his inpatient care, his hospital care, with his outpatient needs. Through the PRIME program, all of the public healthcare systems will be able to expand these types of efforts. And our federal funding through the Care Transitions Project will be based on our ability to make sure that Stanley and other patients are not readmitted to the hospital, that Stanley has all of the information he needs when he's discharged for the hospital so he knows how he can contribute to his own recovery, and that the providers that took care of him in the hospital have coordinated effectively with Stanley's primary care team in the outpatient setting so that he has the follow-up medication and needed appointments necessary to continue along his recovery journey. So that's PRIME. The Global Payment Program is another exciting program in the waiver that, as Ms. Cantwell highlighted, really reorganizes existing federal funding for the public healthcare systems and allows us to focus exclusively on the remaining uninsured and tailor our services in a much more effective and flexible way than we had in the past. This funding was largely concentrated only in the hospital setting, and now we have the opportunity to really expand ambulatory care and primary care services. It incentivizes us to be able to expand non-traditional services that previously we had no ability to seek reimbursement for before, so that's nurse advice lines, health coaching, navigators, those sorts of things. And it continues to support the traditional services as they exist. Unfortunately, people will still need hospitals, and this program will still allow us to support those hospital services when they're needed. As Ms. Cantwell mentioned, the funding for this program is all value-based, so in order for them to achieve their full global payment funding, they have to demonstrate their provision of service and that they've been doing a good job in serving this population. And our systems are just in the midst now of really starting to design what these global payment programs really are going to look like on the ground. Many of them are building on the lessons learned from the low-income health program, thinking about how they're going to want to expand their ambulatory care services so that they can really provide more coordinated and efficient care on the ground. And lastly, I just want to touch on whole person care, because every time I think about this, I get really excited. I get excited about all of them, but whole person care is a new program. For all of us that have worked at the local level, this really builds on the strength of who our communities really are. It allows us to focus on coordination and care integration with multiple agencies that are largely serving the exact same population, but provides a program and a systematic approach to be able to share data and tailor care needs for this population in a way that we haven't done before. Public healthcare systems are already working at the local level with many of their local partners to start to identify who this population is and start to think about how they could design these individualized care plans. Just to give you a sense from one of our systems, the top 1% of their hospital users, of those, 70% were homeless. More than half had been in contact with mental health or substance use services. 70% had at least 3 chronic conditions. And 22% had a record of being in the jail health system in the last 12 months. So this is an incredibly vulnerable population, and there's some really good work happening on the ground to think about how we can improve their overall care. Lastly, I just want to highlight a couple of key takeaways. I think first, the waiver overall really demonstrates California's leadership. Ms. Cantwell's leadership in getting this effort negotiated successfully, but it is allowing us to do some things for the very first time and really focus not just on coverage expansion, but really on improving the health of our communities. There are a lot of really exciting opportunities to make some critical investments in how we deliver care to our patients, but this is ambitious. This is going to be challenging. It will be hard. Many of the programs that I mentioned really require sustained improvement over time. And while it is challenging, I think all of us are embracing this challenge. We are excited about the work ahead, not only because it's the right thing to do, but it's absolutely where we need to go in taking care of our patients in the years ahead. Thank you.
Thank you. We have Shrita Lane, District Hospitals.
Mr. Chair and members, I am Shrita Lane, Vice President of Finance Policy with the District Hospital Leadership Forum. Thank you very much for inviting me to speak today. I'm going to talk about the PRIME program, but do want to say up front that California's district and municipal hospitals are very supportive of all the components in this, in Medi-Cal 2020 and the waiver. As I think somewhat like Ms. Muller said, the district and municipal public hospitals are very enthusiastic about Prime and are very grateful to be included, notwithstanding the tremendous amount of work ahead. We're pleased to be able to have the opportunity to work closely with the Department of Healthcare Services and the folks within the department who have been championing this program for more than 5 years now. We also owe significant gratitude to our colleagues at the within the counties and UCs and at the association at CAPH. They paved the way for this program with their efforts in DSRIP 1.0, and they've been very generous with sharing the lessons learned. The District Hospital Leadership Forum represents California's 40 district and municipal public hospitals, also known as non-designated public hospitals. These hospitals have publicly elected boards of directors, and they are the local government responsible for providing health care for their community or for their district. They're very diverse. There are some very small as 3 acute beds, and then some that are very large, over 400, that provide a tremendous array of services. Like I said, the services are also diverse. Some of those very small hospitals have a very small acute unit, but may provide a host of outpatient services via rural health clinics, and maybe have a distinct part nursing facility to provide long-term care. And then those in the more urban and suburban areas are large and provide tertiary and trauma services as well. These hospitals are located in 28 counties throughout California, from San Diego and Imperial in the south to Modoc County in the north. 2/3 are rural, and 20 have a critical access hospital designation. We, as has been noted, we're not included in DSRIP 1.0, but are now organized and ready to take on the challenge of Prime. There was a commitment 5 years ago by both the department and by members of the legislature to recognize these hospitals in the subsequent waiver, and we're very pleased that that has happened. These hospitals, like I said, are organized both in aggregate and internally and are ready to put forth some of the effort. As Ms. Cantwell mentioned, almost all of these are participating in Prime. The only 2 that are not is the one is not, that is the smallest and most fiscally fragile, and another one that is very soon to affiliate with a private, so it would become a private hospital. These hospitals are doing from 1 project to 11. As Ms. Cantwell also said, though, most are doing more than 1, but some of the very small rurals are doing 1 project. These hospitals chose their projects based on what their community needs were. For example, some hospitals have noticed a gap in cancer screening, so they're putting in place projects related to that. In some of the small and rural areas, the hospital is the only place to receive preventative services, and so they're putting in place to shore up some of the preventative services they provide, and there are a few programs related to that. Others are, because of their location, see a lot of extreme sports, and so therefore are going to put in place a non-malignant chronic pain management clinic. Across the board, our hospitals struggle, as all hospitals and all providers do, with the behavioral health needs of Californians. So that is going to be that's going to be a big project. The most popular, if you will, is the transitions of care. Somewhat like Ms. Muller described, when the patient is released from the acute setting, we want to make sure that they have all the services they need so that they don't come back. You know, they have the medication, they have maybe some community services set up. That is and you know, even the very smallest hospitals are transitioning patients out of the acute unit all the time. A couple of challenges and differences between the district and municipal and the county and UC hospitals are worth mentioning. The first is that district and municipal cannot hire physicians, unlike our colleagues. However, with sometimes a challenge and a program such as Prime, it has caused these hospitals to look more carefully at ways to ensure that their patients are receiving the full array of services that they need and that is outlined in the Prime program. And also, because we're starting a little bit later, we're appreciative of the fact that DHCS was able to include in the construct of the waiver some infrastructure measures in the first few months for the district and municipal public hospitals. That allows the hospitals to spend some time ramping up to get ready to begin the measuring, the very clear and concise goals that we have to reach, as Ms. Muller described. Now that all the applications are in, obviously our attention turns to implementing the projects, and the hospitals are well on their way to working on that. And both at the hospital level and at the association level, we've begun to plan for this end game. The alternative payment methodology requirement that is for the county and UCs does not apply at the end of the waiver for the district and municipal, but we recognize that that's the way the world is going, and so we're working on that, like I said, both internally within each hospital and then within the association. In closing, we're very appreciative of our partnership with DHCS and to members here in the legislature as we move this program forward for district hospitals. We look forward to the application approval and then implementation of these exciting projects that will benefit Medi-Cal beneficiaries throughout California. Thank you.
Thank you. We're going to move on to Kelly Brooks Lindsay speaking on behalf of the counties.
Good afternoon. I'm Kelly Brooks. I'm speaking today on behalf of the California State Association of Counties. We are very supportive of the Medi-Cal 2020 waiver overall, and I've been asked today to speak specifically about the whole person care component. I think it's noteworthy for you all to recognize that the whole person care pilot is the first time that a California waiver has included a project aimed at addressing the social determinants of health. I think there's been a lot of really good thought and discussion about how to address the triple aim and achieve better health outcomes for the varying populations within the Medi-Cal program. And I think the whole person care pilot really recognizes that no one entity is going to do this by themselves. The Medi-Cal managed care plans can't do it alone. The county health agencies aren't going to do it alone. County specialty mental health plans can't do it by themselves, and certainly the providers in the community can't either. That it really is a partnership across public and private systems, thinking about how do we improve the overall health of our communities. I think the pilots are a really great opportunity to sort of build on the local innovation that we know is already out there. I think counties are very comfortable in thinking about how to go forward with whole person care because of the successes of the low-income health program and its predecessor, the coverage initiatives. I think we have a pretty high degree of interest amongst counties, both rural, urban, suburban, counties with hospitals, counties without hospitals, and thinking about how this might be tailored to meet their local needs and address some really, vexing issues around low-income populations. I would be remiss if I did not thank the Department of Healthcare Services for all of their work leading to Medi-Cal 2020. Whole person care evolved from the stakeholder process. It was not, I think, initially on DHCS's radar, but I think through really good collaboration and discussion, this became part of the final waiver package. And they did a ton of work on thinking about the housing component, which is in the whole person care waiver. I'd also like to note that CSAC, along with CAPH, the county behavioral health directors, the county welfare directors, the county health executives, the local health plans of California, SEIU California, and the Corporation for Supportive Housing have all been working in collaboration to think about from the brainchild of whole person care to sort of what it looks like through the waiver development. And we continue to meet and offer learning collaboratives and opportunities for localities to figure out, okay, how would this work for us locally? What are the questions that we need answered so that we can go forward and submit applications? So I think one of the things that is really important to the whole person care pilots is the opportunity to build something that is sustainable beyond the 5 years of the waiver. In thinking about the opportunity to reach across systems so that we're not so siloed, to think about some infrastructure that could be put in place that potentially lasts beyond the 5 years, to think about how we share data across systems and how that becomes a way of doing business so that we're coordinating care in real time, so that we're getting as much information as possible about some of the really high users of multiple systems. I think that is part of the incentive for folks to think about participating is really this opportunity on the data and the infrastructure side. I also think there's a lot of interest in the program, frankly, because of the housing component. I think opportunity aligns with a lot of discussions that are happening locally about how to address homelessness in their communities. It's a very interesting time with the legislature and your interest, and in the Assembly's interest as well, in addressing housing and homelessness issues. And so I think this has people thinking about how housing and health fit together. I think what you will see from the kinds of projects that people are going to embark on, they're going to be thinking about, okay, who are the folks that are utilizing my mental health system, who's in my emergency rooms, who's in my jails, who's calling 911 a lot, and thinking about how to align these folks across systems, look at data, and figure out ways to work together to really address some of these issues. Folks are going to be looking at projects that might include recuperative care, they may include sobering centers, obviously probably housing supports, and thinking about maybe using peer navigators or peer supports in a different way to ensure people are getting to appointments and getting their needs met. Another piece of the whole person care pilot is an evaluation component. So the early years are going to be focused on sort of getting infrastructure up and running, but we're going to have to demonstrate that we're improving health outcomes. And so this is something that I think we're going to end up having other states looking to California, because we may be a national leader in this area. And this, certainly CMS is going to be looking to make sure that California is meeting its goals. I think the last thing I would just mention, I do think that whole person care is an opportunity to leverage some of the policy discussions that are going on, perhaps around the drug Medi-Cal waiver, how these things might fit together, what the department is talking about in terms of implementing health homes in 2017. And so I think this is really an interesting policy time for us in the health community to think about how some of these projects may fit together to improve overall community health. Thank you for having me.
All right. There are going to be questions at this point. Are there questions from the committee? Yes. Who put up their hand first? I didn't see. All right. Senator Monning.
Thank you. Well, I want to thank all the presenters for your amazing work and thank the author for providing this vehicle for us to implement. Clearly, the big success was the extension, the federal government extending the waiver in 2015, and this is now the components of how we do it. So just kind of a 30,000-foot question. This waiver extension expires in 2020. Will we be eligible for a continuation after this?
That's a very good question. Technically, yes. So there is no sort of prohibition on states continuing to seek waivers. I think at least the current viewpoint of CMS and what we heard from them during our negotiations is that they're seeing less and less reasons to have 1115 waivers because they were viewed initially as coverage, vehicles by which states did coverage. Obviously that's changed now. But obviously there will also be new administration at the time that this happens, so can't predict the future. From our perspective, what we're trying to do is how do we take the lessons that we're learning through the work being done here and incorporate it into the base program so that we don't have to seek a waiver to do these things. So we're glad to have the 5 years to have that opportunity, but that certainly doesn't mean that we wouldn't be seeking another waiver in 5 years if we needed to.
Yeah, and that's helpful because I remember in 2015 there wasn't necessarily a guarantee, and the hope was with implementation of the Affordable Care Act, expanded eligibility, we'd be filling some of the gaps that the waiver had filled in the past. But, and I guess related to that, and my math may not be correct here, but it looks like the last waiver was approximately $10 billion of support through 2015. And as I look at page 9 of the staff evaluation here, it looks like we're eligible under this waiver for approximately $6.2 billion. So there's about a $4 billion less, and yet it seems like we have a more ambitious effort to really move more resources into prevention, looking at the whole patient and community support, et cetera, all of which from a public health point of view makes a lot of sense. But it looks like we're being asked maybe to do more with less. And is there a way to summarize why the difference, and who loses because of that difference as we expand to include district hospitals as well, which I am glad to see. And I have one of those close to my district who are very pleased to be included. So.
Sure. So the biggest difference is that that $10 billion included the low-income health program. So money that now we're doing through the Medicaid expansion. So from a year-to-year basis, if we look at the last year of the Bridge to Reform and the first year of this, we're essentially even in terms of funding. So it's not really a loss of funding. Over time, certainly the funding decreases, as I talked about in Prime, and with Global Payment, we don't know the funding for that one component for years 2 through 5. So for the public hospitals, there is going to be some declining funding from what they had in this waiver. And then the other place where there's sort of lost funding is that the state previously was receiving $400 million in general fund savings from the waiver, and that was no longer permitted. Instead, a smaller amount of that was converted into how we're funding the non-federal share of the dental transformation initiative.
Great, and that is helpful, and it explains that we haven't necessarily lost that money, but it's supporting patients through different forms of eligibility. And then I guess for any of you, but maybe starting with Ms. Cantwell, this is ambitious, and it seems like it's designed in a manner that puts patient health, community health, prevention front and center, supplemented with dental support, et cetera. If you had to isolate, what's the biggest challenge for you from an administrative point of view? What support could the legislature be to further help in terms of, not necessarily even within these mandates of the waiver, but in achieving these public health objectives when we know we have trajectories of poor health, obesity, preventable diabetes, cardiac disease? Many of those trajectories are getting worse, not better. I know the hope of some of this emphasis and focus is to get to the front end of some of that, but maybe from an administrative point of view, the biggest challenge you see or where you could use the most help to be successful.
Sure. So I think for us, the role that we play as both sort of providing assistance to our colleagues who will be implementing this, as well as the state infrastructure that we need to have in place to allow for this, the biggest challenge for us relates to data. Getting the right data, getting it in a manner that's workable and usable, and that we can then turn around and report out on what's happening. We do have a position request pending in the budget related to our ability to do a lot of the work for this and to really provide the technical assistance and the leadership to our colleagues for implementing that. So if I had to pick one thing, I would say it relates to all of these programs require a lot of data. Both the IT part of just getting the data, but then also the analytical capabilities to really evaluate what's happening and use that to inform how we would change the programs over the course of the 5 years. And of course, then how do we change the Medi-Cal program more broadly to incorporate them into the program.
Just to comment on that, and I think we have another comment, but so the data collection, part of that is what we're obligated to generate as a condition of the waiver for the feds, but there's really a utility of that data as well, right? In terms of having a better understanding of where we have maybe higher trajectories of poor health and what zip codes are those, what pockets in our communities, et cetera. So this isn't, I think you addressed this, but this data collection happens throughout the course, and so we're not waiting till the end of the 5 years for a final
That's correct.
Data test.
So, I mean, for each of these programs, there's either, for most of them, it's reporting twice a year. And then in some of the cases, it's continuous data submissions. We'll also be capturing data we've never captured before, particularly with respect to the uninsured in the Global Payment Program, getting direct utilization data, including services that we've never captured because we don't pay for it in Medi-Cal. All of that is stuff that we'll be getting on an ongoing basis that we'll use to evaluate and determine whether they all get the payments that they would like to earn, and then use it to both evaluate the program ongoing as well as at the end. As I mentioned, for a couple of the programs, we actually have a midpoint evaluation we're required to do, but each of the individual participants have reporting that they do to us for us to evaluate their progress over the course of the 5 years.
Thank you. And I think one other comment.
So I agree with Ms. Cantwell on the data piece. I think it's going to be challenging to figure out all the data sharing agreements that need to be in place for whole person care amongst different entities, public and private, which direction the information can go, and sort of figuring out, okay, what can we do under state law, what can we do under federal law, and sort of where do we have some room to be creative about the rules. But I think it's not just with whole person care, but with anything that we're talking about where we have to collaborate better and use data, I think these conversations are going to be really pivotal.
Thank you. And then just a final comment, again, to thank you all for your respective roles. It was referenced in the presentation, I think, on the county hospitals, which I also proudly have close to my district, serves people in my district as teaching hospitals. And our experience with county hospitals that are also teaching hospitals, that's often the entryway into underserved communities for doctors who get their training and then stay in the community. And a lot of the doctors currently practicing in underserved areas of Monterey County were trained at the county hospital. So it's another value added to our support for the county public hospitals that also serve as teaching hospitals. So again, thank you, Madam Chair.
All right. Dr. Penn, you're on.
All right, well, thank you so much for your presentation, and I appreciate the thought that went into this waiver. I know that, well, I personally was a little disappointed that that the feds, I know that's from CMS, you tried hard in terms of the amount of money, given our leadership in trying to implement the ACA and the Medi-Cal expansion. I think we should have earned more. We should have gotten more because I think our success is important to the overall success of the ACA. Certainly, I think, given what you've had to work with, I appreciate the effort to address social determinants of health, I think with the whole person model and so forth. A few questions. So first of all, we've had in California through our Medi-Cal program, said we're working on coordinated care, we've moved people to managed care, and so here we have the PRIME, which talks about hospitals trying to do more with outpatient and coordination. So what's the intersection between PRIME and the Medi-Cal managed care plans that all these hospitals, practically every county is Medi-Cal managed care at this point. So what's the intersection? So you have the managed care plan supposedly coordinating, you have a hospital that's supposed to now try to move out. So how do these two programs intersect?
Sure, I'll start, and certainly I think Ms. Muller probably would like to add to that. So the people who are a part of this program, who are being measured, and the things that they're doing are people who are enrolled in the managed care plans, and so it's through their contracts with them. So it's, in many cases, the public hospital systems have contracts, or in almost all cases, they have contracts with the Medi-Cal managed care plans. And so what we're focusing on is the outcomes that they're going to drive. So they actually serve as primary care homes for many Medi-Cal managed care patients. The alternative payment methodology requirement that I mentioned earlier is linked to that. And so we really see that this is additional money that they're getting in addition to what they're being paid by the plan to organize the care for the people that the plan has assigned to them.
So to clarify, and I know that I'm sure you want to weigh in as well, but to clarify, who's responsible for, on the accountability side, for ensuring that through the PRIME program, the hospital, the network, because not just the hospital trying to do more outpatient, is achieving the goals? Is it the department, or are you deferring that to the plans? So, yeah.